am I dealing with this? Because the diagnosis usually is clinical, so you can't actually say until I have this, but you already have at the back of your mind what are the symptoms I'm expecting in case this doesn't resolve within 3 to 5 days. Of course, those with allergic rhinitis, for example, of course, inflammation there. Of course, those particular ones, they have history of allergy. And of course, there are bouts of sneezing. They are always on the high, itching the high, either is the nose or they are scratching their throat. Of course, those ones, you know, there's that atopy there or there's history of allergy. You can use to differentiate that from bacterial sinusitis. Of course, they also have watery eye, but they won't have mucopurulent discharge. It's usually a clear fluid. And then most time, of course, you won't even have any loss of smell. It's not likely. Other differential diagnosis is facial pain. Of course, it could be due to migraine, cluster headache, or some absence of other, maybe some other things that the patient may have. So those are like other differential diagnoses to bacterial sinusitis. But of course, for that facial pain, by the time you do an endoscopic or radiologic finding, you're actually going to find a normal mucosa. It won't be like the inflamed mucosa we have in a bacterial sinusitis. Of course, fungal sinusitis that I've earlier mentioned is also a differential diagnosis. Yes, of course, by the patient just presenting to you, you can't actually say, yes, this is what you have. Most time we tend to actually have, in terms of severity, and then by the time we're doing other radiological studies like a CT, is then we're able to pick calcifications, and that signifies that the patient has fungal sinusitis. So, of course, it's something you have to be on the lookout for. Investigation usually is based on clinical symptoms. For sinusitis, you are not expected to go and be doing X-ray or you want to go and do a CT scan. Just clinical diagnosis of those symptoms can actually diagnose bacterial sinusitis. Or maybe if now the issues, the symptoms are not improving, then maybe you can now, okay, can a patient have nasal endoscopy? Of course, with the nasal endoscopy, then you can ask, okay, you're going to find inflammations, and so you're going to see the mucosa, is it engorged, is it edematous? Of course, you'll have been managing empirically with the drugs that we're using. Then plain X-ray, most time will not really show anything much. But if at all, you may just have maybe an opacity in any of these sinuses, mostly maybe the maxillary sinus, or you have air fluid level. CT scan is only indicated when only when there are complications, you are suspecting complications. Then, of course, you can say a skin prick, maybe for those that have allergy. This is of a picture trying to show like a patient having maxillary sinusitis. This is the antrum. This is the normal side. It looks black. But by the time you are having this, that means opaque, and at times you can have air fluid level. So this patient has bacterial sinusitis. This is the maxillary antrum. Then you could see the engorged turbinate. This is the nasal cavity here. And then look at the septum. It's kind of deviated here. So this patient is actually prone to having the bacterial sinusitis. This is the truth. So these are the maxillary. This is a normal appearance of a sinus that doesn't have any issue. But there's opacity of this, okay? Treatment plan, of course, when you watch, we call you watching, the patient is not getting better. Of course, we want to maybe commence oral antibiotics. Yes, we want to maybe give nasal decongestant to reduce, because there's edema. You want to reduce the edema in the nasal cavity, in the sinuses. Yes, maybe you can see how maybe you could tell them to have like a steam inhalation to help just to reduce edema and help the patient reduce the congestion. Of course, patient having pains from the facial pain, you can't give them analgesic to use. Then if that, of course, is not helping, you can also give intranasal steroid. That will also help to decongest and also reduce the swelling and the inflammation in the nasal cavity. Some says hot fermentation be applied some hot application to the area where there's pain. But if all this is not working within 12 weeks, please refer to an ENT surgeon. Yes, I call these red flags symptoms. These are symptoms to actually watch for, because you could see that the eye, the nose, the cheek, everywhere is actually close to the sinuses. So any infection from any of these places can actually spread, either from the nose, you can spread to the gum, to the brain, to the eye. So when you're having a patient with perioptic edema, a patient with swelling, a displaced lobe, visual impairment, that means ophthalmoplegia, that's pain in the eye. Diplopia, having one, that's one object becoming two. You know, there's already a complication of this thing. So please refer. Or you're having severe unilateral headaches, bilateral frontal headaches, or frontal swelling, or patient is having some neurological sign or reduced consciousness. These are red flags that please this patient has to go refer to the specialist. Antibiotics to use, like I said, you use antibiotic. The first line drug to use is amoxicillin clavulanate. And then it goes like that. Maybe then cephalosporin, if of course, if the patient is not doing well, but the first line drug is amoxicillin clavulanate. Then, of course, the other ones are there on the slides, ciprofloxacin, levofloxacin, those are the quinolones. Then, of course, you can see go on clarithromycin, but the first line drug is amoxicillin clavulanate. Then the duration of use of antibiotics, of course, you use it, of course, up to like 3 weeks, with improvement in symptoms, maybe 3 to 5 days, of course. The way the patient is actually responding will actually determine if you're winning or we're actually losing. So, of course, by the time we start the medication, within 3 to 5 days, patient should get better. If it doesn't resolve, of course, symptoms within 7 to 10 days, after which there's no improvement, another week you can continue. Maybe there, of course, to help diminish the mucosal edema,